Hello, my name is Benjamin Gundlach. I'm a hand and upper extremity surgeon at Boston Children's Hospital. I'd like to give thanks to the Harvard Global Orthopedics Collaborative for the invitation to speak today. I'm going to be discussing the anatomy, epidemiology, pathophysiology, and evaluation of brachial plexus birth injury. Objectives for this talk are to review the anatomy of the brachial plexus and peripheral nerves, as well as the anatomy of peripheral nerve injury as it pertains to brachial plexus birth injury. I'd also like to discuss the epidemiology and risk factors for this injury, as well as the evaluation of the brachial plexus birth injury patient. To begin, the brachial plexus is a network of nerves that originates from the cervical and thoracic spinal cord at the C5, C6, C7, C8, and T1 levels. Each nerve root descends through the neck and then arm, forming trunks, divisions, cords, and ultimately terminal motor branches, which go on to provide the majority of upper limb motor and sensory function. In a broad sense, we think of the C5 root as providing shoulder function, the C6 root providing elbow flexion, the C7 root as providing elbow, wrist, and finger extension, and the C8 and T1 roots combining to provide finger flexion and intrinsic hand function. In reality, though, there is considerable redundancy in these innervation patterns, with each root having considerable overlapping contributions to adjacent motor groups. And we know that because of studies like this one, performed by Dr. Gu, who was a real innovator in performing the contralateral C7 nerve transfer. And in the process of developing that operation, he brilliantly recorded the innervation patterns that he experienced in normal brachial plexuses that he was operating on. And the summary of the data that he collected can be seen here. And so what this provides us is very objective information to the functional innervation patterns in the normal brachial plexus. So what this allows us to see is things like in the biceps, which we classically think of as being C6 innervated, in reality gets almost the same amount of contribution from the C5 root as it does the C6 nerve root. This is opposed to other muscle groups like the latissimus, which receives a very narrow amount of its innervation from the C7 nerve root, and the remaining nerve roots have very little contribution. And then we see other nerve roots or other muscle groups like the FCU again, for example, which we think of as being a lower trunk muscle group or innervated by the ulnar nerve. In reality, it receives an equal contribution from C7, C8, and T1. So more broadly, we look at a table like this and see that there's considerable overlap from one nerve root to another and other muscle groups that we don't classically associate with them. Another area where we see this is this paper that was performed by Dr. Clark out of the Toronto group, in which they looked at children who had recently undergone nerve grafting of the C5, C6, C7, and C8 roots, leaving only a T1 root left. And immediately following surgery and the subsequent weeks afterwards, they performed physical examinations on these children, which allowed them to ascertain what function is provided, at least in infants, by the T1 root. And what they found is really surprising. Again, we classically would consider the T1 nerve root as really only providing hand function or intrinsic hand function, when in reality, it has a very broad innervation pattern, even in things that we would never typically associate with lower trunk function, like elbow extension, which was seen in a quarter of patients with only a T1 nerve root. And in 6 of those 40 patients, they had an AMS of 6 or 7. This ultimately led them to conclude in their paper that as a consequence of this data, the diagnostic specificity of things like the waiter's tip posture, which we associate with an upper trunk injury only, at least in the infant, is less reliable than was originally thought. Moving from the macroscopic to the microscopic, it's also very important to have an understanding of the microanatomy of the peripheral nerve. Seen here is an illustration detailing such. What we see here are individual axons in their myelin sheaths, which are grouped together in an endoneurium and perineurium, and ultimately go on to contribute to a fascicle. And these fascicles are really the first structures that we're able to resolve and see from a clinical standpoint. And having an understanding of fascicular architecture also becomes important for reconstructive purposes when we talk about things like fascicular nerve transfers. For the purposes of injury, though, it's also important to understand these structures because, as we'll see in the next slide, we classify nerve injury based on which of these structures are injured. Multiple fascicles are then contained together in more connective tissue, which in part provides vascularity to the peripheral nerve. And all of this is ultimately contained within an epineurium. And it's this structure that we then go on to consider the peripheral nerve. As I mentioned, having an understanding of these structures is very valuable in allowing us to more accurately describe a peripheral nerve injury. And work that was done by Dr. Seddon and Sunderland can be seen here. In a broad sense, we have three large injury classifications. The neuropraxias are the stretch injuries that lead to a loss of myelin only, and all of the other structures that we just saw are left intact. From a clinical standpoint, these are the brachial plexus birth injury patients that are said to have had a quote unquote stretch injury and resolve in a matter of days to weeks. With further successive injury to other structures, we begin to see axonometric injuries, where not only the myelin is injured, but the axons as well. And ultimately, a neurometic injury is a complete transection or rupture of the peripheral nerve. Now, others like Sunderland sought to further classify peripheral nerve injuries, understanding that there were more structures being injured than just the myelin and axons and epineurium. And so these axonometric injuries were really broken into several different categories in grades 1, 2, 3, 4, and 5. And with each successive grade, we see an additional structure being injured, from myelin to the axon and endoneurium, and axon, endoneurium, and perineurium, and then ultimately a full transection. And what we see clinically as with increasing severity of injury or with more structures injured, there's either going to be more time required to allow for spontaneous regeneration, or in more severe injuries, the lack of ability for a nerve to truly recover on its own. Once we begin to experience axonometric injuries is when we'll also start to see Wallerian degeneration. And once we have Wallerian degeneration, we can begin to expect a much longer recovery of that nerve. In a basic sense, once that axonometric injury happens, we see Wallerian degeneration where the distal axon is cleared and an axonal outgrowth starts to mature at the node of Ranvier most proximal to the site of injury. Once that axonal outgrowth begins via a growth cone that develops, the Schwann cells of the peripheral nerve also metamorphosize into more macrophage-like cells, which also begin to metabolize and digest the distal segment of nerve injury. And from here, this process then allows for the outgrowth of the axon, the remyelination and reestablishment of these neuromuscular junctions. In a very broad sense, this is what nerve regrowth and recovery must look like. When it comes to brachial plexus birth injuries, another anatomic importance to consider when classifying nerve injuries is looking at the location in which the nerve injury happened. In a very broad sense, we categorize these as ruptures and avulsions, or preganglionic and postganglionic injuries. This is equally important in understanding from a clinical sense in that difference in location and where the injury happens allows for different reconstructive options. Specifically, avulsions, in which the nerve root has been avulsed from the spinal cord and the individual rootlets, does not allow for really any ability to reconstruct that nerve root. Whereas a rupture or postganglionic injury, in at least some patients, provides the opportunity for resection and grafting. And so being able to make a diagnosis or have an understanding in which a nerve has been avulsed or ruptured becomes extremely important for the surgical management of these patients. It's also important in understanding not just the immediate injury and reconstructive needs of that patient, but also more long-term outlook in that patient and the function of their upper extremity. And we see this in studies like this one that was performed by Dr. Cornwall earlier last decade, looking at the effect that pre and postganglionic injuries may have on secondary muscle growth and contracture development in the upper extremity. And seen here is a mouse model in which preganglionic injuries were shown to have better preservation of afferent innervation. And this preservation of afferent innervation to the muscle spindles within the deinnervated muscle may reduce the muscle shortening and contracture that was developed. This was shown in his basic science model, but then this idea was also investigated in a clinical model, which was published in a very nice study by Dr. Pandug and Malaysi, in which they reviewed their cohort of patients, and even in the C5 and C6 injury model, looking at nerve root ruptures and avulsions, or preganglionic and postganglionic injuries, and going on and then looking in which patients developed worsening internal rotation contracture further in adolescence. And what they showed was very similar to what Dr. Cornwall showed, is in that patients that had a higher burden of avulsion, specifically patients that had avulsions of both C5 and C6, had dramatically less internal rotation contracture compared to patients that had rupture or postganglionic injury of C5 and C6. Moving on to discuss some of the causes of brachial plexus birth injury. Ultimately, this injury happens due to a traction or force applied to the brachial plexus birth injury that at a time when there was an increased angle between the neck and shoulder during delivery. This leads to a successive traction on the nerve roots, starting from C5 and descending from C6 to C7 to C8, and then ultimately T1. Broadly, brachial plexus birth injury is said to have an incidence, at least in modern times, of 1 in 1,000 live births. However, uh, it in fact has much more variability than that statistic contains. And so when we look either temporally or internationally in various countries, we see that there's still a lot of variability in the incidence of brachial plexus birth injury. Some countries like the United Kingdom have reported more recently very low incidence of brachial plexus birth injury and only 0.42 in 1,000 live births. In the United States, our incidence has hovered around 1 in 1,000 live births for many years. And this has been similarly demonstrated in nice retrospective studies out of Turkey. However, other countries, such as out of Kosovo and Nigeria within the last decade, have still demonstrated an incidence 2 to 4 times greater than this 1 in 1,000 live birth statistics. In a nice review that was published here by Chow et al., we see this variability nicely displayed in more objective data. What this data also shows us is that cesarean deliveries in countries that have a higher prevalence of cesarean deliveries are shown to have significantly lower rates of brachial plexus birth injury. Risk factors for brachial plexus birth injury has been reviewed exhaustively over many decades. And what we know is that the greatest risk factor for brachial plexus birth injury is the occurrence of a shoulder dystocia during the delivery process. In a review by Foed et al. From last decade, shoulder dystocia was found to have a 100 times increased risk of brachial plexus birth injury. Additional risk factors are a large infant with a birth weight of 4.5 kilograms or greater, the need for assist in delivery, such as forceps or vacuum, as well as maternal diabetes. However, there is significant overlap with these other risk factors and the ultimate occurrence of a shoulder dystocia. Again, what has also been demonstrated in several studies is the protective effect that cesarean delivery can have on lowering the incidence of brachial plexus birth injury. When dealing with an infant, especially during the first evaluation that is coming with an assumed diagnosis of brachial plexus birth injury, it's very important to keep an open mind and have other things on the differential that may also lead to decreased movement of an upper extremity. Um, Things like a clavicle fracture or a humerus fracture can also be very commonly associated with a difficult birth and can also present with an infant that has very limited movement in the upper extremity due to pain. Importantly, though, these injuries or these fractures in the young infant heal remarkably quickly. And so the expectation, if this is the source of the decreased movement, quote unquote pseudoparalysis, once enough callus forms and the fracture stabilizes, we would expect to see a dramatic increase in movement. Also, it's important to keep in mind that especially the children that have very traumatic birthing processes have very prolonged labor and may have had an anoxic event, that there could also be a more central cause to their diminished movement. Additionally, things like a cervical spine injury must also be in the back of the clinician's mind, especially if patients are presenting with bilateral symptoms. Other associated diagnoses or things that can be seen in concurrence with a brachial plexus birth injury are a phrenic nerve palsy, and this requires the astute observation of the clinician and can be missed. Um, it's not always immediately obvious that a child has a phrenic nerve injury, um, but it's important to ask the parents or the caregivers things like how the child is eating. A phrenic nerve injury, either in isolation or associated with a brachial plexus birth injury, may have a child that still oxygenates fine and doesn't seem to have increased labor of breathing until they do things like eat, and then can experience a phenomenon where they almost need to stop eating to take a breath, and may unlatch and breathe heavily. And so it's important to ask parents or caregivers about this and have a high suspicion if they do voice concerns. Seen here is a chest X-ray of an infant with a brachial plexus birth injury that has hemidiaphragmatic elevation and was found to have a phrenic nerve injury. Other investigative tools are things like ultrasound, which can be used, which are limit radiation exposure and allow for fairly quick as well as dynamic visualization at a diaphragm and can aid in diagnosing phrenic nerve injury. Additionally, torticollis can have a high prevalence of a co-occurrence with brachial plexus birth injury. And this can either be a true torticollis, in which the patient cannot actively and the clinician cannot passively bring the neck to midline into the contralateral side. However, even in patients that don't have true contracture torticollis, uh, either due to the injury, discomfort from the injury, and other factors, these patients can have a preference of sidedness for gaze. And so when evaluating the infant with brachial plexus birth injury, it's important to assess the suppleness of the neck and the ability to bring the head to midline into the contralateral side. And in the coaching process or therapy process of working with these families, educating them on introducing these stretches to try and prevent a more rigid contracture of the neck position. Another more specific finding that can be seen in brachial plexus birth injury patients is Horner syndrome. Um, Seen here is a infant with a Horner syndrome, as can be seen by the lowering of the eyelid. And Horner syndrome is due to a co-concurrence or injury of the sympathetic chain of the cervical of the cervical sympathetic chain. And we think of this as being pathognomonic for nerve root avulsion. Now, more work has been published on this, demonstrating that Horner's can be seen in in injuries where there was not an avulsion to C8 or T1, such as C7 avulsions. However, classically, this still is associated with more lower root avulsions. Moving on to evaluation of the brachial plexus birth injury patient, there are a number of classification systems that have been proposed over time. However, the active movement scale proposed by Dr. Clark and others out of Toronto has become a very popular tool for assessing the infant with a brachial plexus birth injury patient. And seen here on the bottom right is the grading classification scale, which starts at a 0 for no contraction, um, and goes up to a 7, which is full motion against gravity. It's important to know with the AMS in that patients must have full gravity eliminated motion or a score of 4 before they can move on to scoring anti-gravity motion. The AMS is also really helpful in that it allows for um, uh, comparison from examination to examination and allows for serial examinations and providing objective data in improvement as infants are aging. Another important evaluative tool is the Mallet score, which looks to categorize shoulder function in the brachial plexus birth injury patient. The Mallet score was originally proposed in 1972 and was further modified in 2012 to add internal rotation to the abdomen. The Mallet score, similar to the AMS, is the de facto uh, uh, categorization or evaluation tool for the shoulder and brachial plexus birth injury patients. However, it does require the attention of and ability to follow directions from patients, and for that reason doesn't become really valuable until the patient is about 2 or 3 years old. Additional evaluations or tools in evaluating the brachial plexus birth injury patients are MRIs, EMGs, and ultrasound. And these are very institution or region specific in their value in evaluating these patients. Seen on the right here are images of a nap time MRI which my partner, Dr. Bauer, will talk to you about in their lecture. But this is a non-sedated MRI protocol that has been developed by our providers here and allows for the assessment of brachial plexus birth injury patients and has allowed for the development of heat maps, in which they're called, and a more accurate assessment of injury patterns. And so this is a tool locally that is used quite commonly to evaluate these patients. However, it does require that an institution can support this testing, specifically getting MRIs in non-sedated infants in which they're fed and swaddled, and the MRI occurs while the infant is napping. And so this can't be done elsewhere. And so the utility of an MRI in those situations in which an infant requires general anesthesia becomes less viable in other places. EMG and nerve conduction studies are another group of tests that in some centers are very commonly performed, and providers find extreme value in these tests, whereas other centers almost never get EMG and nerve conduction testing, either due to feasibility, in which they don't have contributors to the brachial plexus program and allow for easy access to these testing, or have not found the data that it provides useful. Similarly, ultrasound is another test that has been used to, in more real time, categorize nerve root injuries, as well as allows for easy real-time dynamic imaging of the shoulder in brachial plexus birth injury. Ultimately, though, all of these evaluations uh, um, are required to be done over time, and that's where their true importance comes in. And so the mainstay for evaluation of the pediatric brachial plexus birth injury patient are these examination tools we talked about that are repeated over time. In our practice, we will see infants from birth and see them every month for at least the first 6 months of age. The reason that we do this is multifactorial. We know that in the majority of infants, they will recover spontaneously within the first 3 months of their life. And so seeing them throughout this process and tracking this recovery allows us to help with prognostication of these patients. It also allows us to educate families. And for infants that are not recovering, it allows us to indicate surgery in prompt fashion. Seen here is a study that was performed out of our institution a number of years ago by Dr. Waters, in which the value of these serial exams was demonstrated very nicely. This study looked to categorize the AMS value of elbow flexion specifically, or return of elbow flexion, the month in which that occurred, and then ultimately the Mallet classification or shoulder function of these children years later, and assess the recovery. And what they found, or what Dr. Waters found, is that children that recovered elbow flexion within the first month of life went on to have near normal shoulder function, with Mallet of 5 in all major categories. But what we can see here is that even children that recovered elbow flexion within 2 or 3 months of life ultimately went on to have greater shoulder function than a cohort of patients that were reconstructed surgically. However, we also see here that they do not have normal shoulder function. And the cutoff point in this study was 6 months, in which we see the ultimate outcome of shoulder function falling beneath the level of surgically reconstructed patients. And so This highlights the value in multiple repeated assessments performed monthly in really allowing for prognostication of recovery and also indicating patients for surgical reconstruction. And with that, will allow for the transition into our subsequent talk, which is the early reconstruction and nerve operations in the brachial plexus birth injuries. And I thank you all for listening in today.